Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. Today, we have a fantastic periodontist, Dr. John Kim, who's part of our Case Bites professional team, presenting a case to us. We are really excited to have you, Dr. Kim. So please take it away.
Thank you so much for that lovely intro. I'm very honored and humbled to share the forum with this elite group of specialists here. Today, I'm going to present Mr. Jones here. He's a very nice gentleman, referred to me for an implant evaluation due to a perforation on number 25 during an attempted root canal therapy. His chief complaint was, I know that I'm going to lose a tooth, and I just do not want to have a gap here when I do lose this tooth here. Aesthetics, it's not a big concern for Mr. Jones, but he does, again, like I said earlier, want to make sure that he does have a plan for losing this tooth. His medical history involves the following. He takes an oral suspension of amlodipine to help manage his hypertension. With dieting and exercise, he tries to help control his cholesterol. He's on omeprazole for gastroesophageal reflux disease, which has improved significantly after a Lynx device was placed around the lower esophageal sphincter during a minimally invasive procedure. Unfortunately, he did have a complication with ileus in which he had to be hospitalized for 2 weeks last year. And he is a former smoker. Okay, he had smoked for about 11 years, quit in 2006. So that was great. But when he quit smoking, he unfortunately picked up the habit of chewing tobacco, which is unfortunately quite common in my area. Here's a full mouth series, and it shows good horizontal bone level overall. Maybe there's a mild to moderate horizontal bone loss in the mandibular anterior. You can see that it is a highly restored dentition with multiple root canal treated teeth. And the main reason why he did see me to begin with was this periapical radiolucency here in 25, but more so the perforation on number 25. As Mr. Jones was in for an implant consult, we did take a cone beam CT scan, and I apologize as this is not the clearest image, but what you can appreciate is what you quite often see in the mandibular anterior region is a very thin ridge. And it also appears that there's very little to no buccal or lingual plate remaining. And we can also confirm that there's a periapical radiolucency for number 25, which was very obvious on the PA. And this CBCT pretty much tells me the obvious here, that this can be quite a challenging case for a surgeon, because we know that in this type of area where it's a little bit more avascular, more dense bone, the bone is very thin, that we're likely going to need a few surgeries to augment enough bone to accommodate a future dental implant. Our intraoral exam reveals the following. He has mild class 2 occlusion on the left side with the presence of a mild anterior open bite. You can appreciate a midline discrepancy from the frontal view. He's missing some premolars due to extractions for orthodontics when he was a teenager. There's crowding present, and it appears that it's worse in the mandibular arch in the anterior. And there appears to be some erosion and possible toothbrush abrasion. You can see that there's also some caries on number 29 and a defective restoration, number 30. And just based on looking at the soft tissue closure or healing here, number 31 was not extracted too long ago. So on to my specialty here, perio. Overall, the clinical exam showed that he has a stable periodontium. Yeah, he has a few isolated 4mm probing depths, but there was only minimal pinpoint bleeding on probing. You could appreciate that this patient does have a thick periodontal phenotype, and he does have Miller class 3 gingival recession defects affecting mainly the mandibular arch. And it's important to know the classification because this classification helps give us a prognostic value on the treatment and what to expect with the treatment outcome. So I quite often will use the Miller classification when I discuss this type of case with my referring dentist, the orthodontist, the specialist, and to my patient. Make sure that they have an understanding of what to expect. As there is minimal keratinized tissue and no attached gingiva for number 24. It's very fortunate that he has no teeth mobility and there was no fremitus noted. As a periodontist, these are some of the things that immediately concern me. Implant therapy will be tough due to the limited spacing and crowding. In addition, as a patient chews tobacco, I do not see the gingival grafting procedures to be as predictably as I would like unless he could really cut down or stop this habit. And you could easily see that he is still frequently chewing here. If you look at these photos here with the soft fissured gray-white lesions visible on the lower labial mucosa. And this gives the appearance of a wrinkled appearance of the mucosa here. And what you'll also see in these patients who chew tobacco is that you'll see that there's quite often gingival recession in the area that they chew or pack the chewing tobacco. As I mentioned earlier, Mr. Jones wants to keep things just very simple. He's such a pleasant guy, and really, he just cares about making sure he does not have a gap when this tooth is removed. With regards to the facial analysis, the interpupillary line is parallel to the occlusal plane. The maxillary teeth are coincident with the philtrum, and you can see that the upper and lower lips are thin, and both the lips and the maxilla are retruded. Looking at the profile photos, Mr. Jones has a long lower face height, and the lips are retrusive to the E-line that you can see in a red line, and this leads to a larger nasolabial angle. Some more things to note from the dental facial analysis. He does have, I believe, more so an average smile line. You could appreciate the larger buccal corridor space present. And when in full smile, it looks like he maybe shows about 10 teeth. And as a periodontist, what is most striking to me is the lack of soft tissue symmetry, particularly in the mandibular arch, and where you could appreciate that there are very uneven gingival margins due to the recession. So on to what I think is the ideal treatment plan, and I'd love to hear what you think about this. But what I thought would be best for Mr. Jones is to refer him to get an orthodontic and prosthodontic evaluation. I think it's very important for us to have any chance with success in mucogingival surgery that we do talk about him stopping the chewing tobacco, as we're not going to get the results we want. And mucogingival surgery, particularly in the mandibular arch, even though with a thicker phenotype, may be needed if he's going to have some orthodontic tooth movement. Eventually, he's going to have number 25 extracted. Wanted to know if orthodontics could be used to close in the space in the mandibular anterior, and at the same time also address the malocclusion. Eventually, I'd like for him to get an implant for number 31. As far as I'm aware, he did not have that area site preserved, so likely he'll need a ridge augmentation to accommodate an implant for number 31. And of course, anything else that's needed restoratively, need for my dentist or prosthodontist to address. So I leave this PA or these PAs here for you to look at. And in this type of case here, I would like to know from our elite group of specialists here, what is the best way to handle this case? When this tooth is lost or when we have to extract it, do we just stick purely with ortho? Do we think about doing a bridge? I know we considered implant therapy, but I honestly was not too high on that. So here's my case on Mr. Jones here, and I do look forward to hearing some of your insight.
Well, Dr. Kim, thank you for presenting this case because this is such a classic type of case for a specialist. So a periodontist that is now bringing a patient like this to an interdisciplinary approach, because there's a possibility of ortho and there's, of course, the restorative needs here of the patient. So as restorative and prosthodontists and also as orthodontists, we want to see, hey, what you've laid out so nicely is here are the issues that we have. And I think in the collaborative conversations between the disciplines of perio, ortho, pros, and restorative, it's like, here's the problems. How can we visualize what the ideal situation is from an aesthetic, but also from a structure, function, and biological standpoint? And so if we can visualize that through some type of forecasting of what orthodontics can create, kind of like a clin check and that ability, and also a digital diagnostic wax up or analog, it allow us to look at the different options and objectives. If we're extracting the teeth and moving teeth into proper position, to me, this is a wonderful case where all the disciplines are working tightly together to come up with the best visualized solution. And once we know that together, we figure out what kind of orthodontics might be employed and how are we potentially working together, of course, prosthodontically to create proper occlusion, because a lot of those teeth are malocclusion and teeth are not in ideal positions. So I'm going to pause because I would love to hear from our esteemed colleagues, both ortho and restorative and pros, of how you would visualize it and how do you go about treating this.
To me, it seems like 90% of our cases would benefit from expansion. And looking at patient's profile, I feel Dr. Robles' technique for surgical orthodontics would be very beneficial here. So I would love to hear Dr. Robles' input on this.
Thank you for bringing this case to the group. I think this is a great classic routine. I say routine because it's so textbook in so many different regards. Okay. And, I want to be careful not to beat a dead horse to death. But this is something that has been going on since birth. Okay. And this is what we have to start realizing in dentistry. This is not something that all of a sudden happened with the lower tooth. He's been building towards this since the day, probably since before he was born. Okay. And what's interesting, I don't know how much you want me to get into this or not, but this, again, his whole lower face is developed. It's like the orbits of the eyes and the cranium. They don't develop in the eyes fill them, or the cranium doesn't develop and the brain fills it. It's the opposite. The eyes and the orbits form to house the eyes and the muscles properly. And if you have one eye that's injured, you have different size orbits. Well, the whole lower face is secondary to function. And so this is a classic lifelong airway patient. And to make matters worse, it's a lifelong GERD, probably silent GERD, secondary to airway. And again, I don't want to keep beating this dead horse, but that's exactly what I feel has been going on. Now, look at his skeletal type, the long lower face, the auto rotation, the retroclined teeth. And he was treated with routine orthodontic therapy that we were all trained, is that he had too many teeth for the size jaws he had, so we took out teeth. And, that doesn't cause airway problems. But by taking out the teeth, we're treating to the problem, not correcting the problem, okay? And even this is a classic example of several different studies, that when you look at alveolar bone, especially the periodontist involved in this, there's some classic literature. Handelman did a great study on cases like this, and we call it, what are the limits of orthodontic movement? And we call those orthodontic walls, and it's a buccal and lingual cortical plates. And that's what the alveolar trough is about, that we can freely move teeth in. But if you try to violate the cortical plate, you get iatrogenic tissue loss, being root structure, soft tissue, hard tissue. Well, the fascinating thing about it is the whole orthodontic walls is dependent on the vertical dimension of the lower face. And so think of the alveolar ridges as saltwater taffy. And if you have a low angle person with big, strong jaws, their cortical plates are far apart. You have this huge trough. The normal patient has a good standard buccal lingual orthodontic trough, but you get the high angle, the body is using it to compensate, and it's almost stretching that alveolar bone, and these lower incisors are on a pedestal, setting up this type of problem with somebody that has a thick biotype, which, he has that going for him. And so this is what makes the complicated issues, And so we have to start peeling back the layers of the onion. And because if you just start saying, macho me, I'm going to do orthodontics and close that space, well, you could easily blow out the lingual plate. Okay. And so this is where understanding and working with great periodontists that can change the limits, change the orthodontic walls is so critical. Okay. And so that's where I would be going, is I would be looking at developing. I would actually look at expanding, developing the upper arch. Really, he's an orthodontic case at this particular point in time. We've missed the major opportunities. And so to be honest with you, ideal treatment for him, especially when you get a diagnosis of OSA, which I'll put money on the table he has, is that, is to treat the dentalveolar complex, the perio, get things stabilized, take out that tooth, do SFOT, close it the best you can, get the relationship right, and then do double jaw surgery, in my opinion, would be the best. Okay. And we could do all that with clear aligners, by the way. That would be my preference. Does that answer any questions there? I mean, does that seem realistic to you all?
Rick, is there another alternative once you did SFOT with a concomitant ortho grafting? Is there an option where you're not doing the double jaw surgery?
Yeah, there are definitely options. Okay, and this is where, when we do treatment plans on cases like this, we look at 3 different types of treatment plans. Interdisciplinary ideal, which is I just mentioned. What's the best we have to treat this problem? And of course, he needs a whole host of restorative. I didn't even touch on that.
Right.
In implants in the posterior. And then we look at what is interdisciplinary alternatives, okay? And then what is interdisciplinary phasing? So there's 3. Because the last thing we want to do is go in there, especially with an airway patient, is, at his age, it's going to do nothing but get worse. And so we want to leave that MMA, that maxillomandibular advancement option, open. We don't want to shut the door on that. So I'm going to do anything possible to increase his oral volume, increase the infrastructure, and make room, but leave MMA open. And so basically it would be the exact same treatment plan that I just described, except we would open spaces as much as we could, stretching those deficient orthodontic walls through, augmentation, and then tell them, ideally you need, MMA. That's your treatment. We're trying to stabilize stuff until you decide to do it. And so that's how I would do it. And I would try to get him more oral volume. Can you go back to his smile again? Because he's not really a gummy display. It's mostly in the mandible that, so he's not real gummy. You could move his teeth up some, and that would help him a lot. If you moved all of his upper arch up 2 to 3 millimeters, that would rotate his mandible forward. For every millimeter you intrude an upper first molar, you're advancing chin point 2 millimeters. Okay. And so it really changes, and you're changing the vertical height too. So, all these things fit in. So you could do anchorage in orthodontics to expand. If it was a female, I would be doing a bone-borne expander. Okay. Because we do that up until age 70. Up to age 30, males are very sketchy. Something about being thick-headed. I'm not sure what.
Yeah.
Told. But and so that would be my alternative, is to keep doing that, but keeping the option for MMA open.
Yeah. This conversation reminds me of my old pathology professor back at Boston University, he would use a line that the eyes do not see what the mind does not know. Mm-hmm. And so many things that Dr. Robley's talking about, expanding our thinking and bringing, this whole situation of airway, of medical condition, of structure and functional issues that can be helped by our therapy and our therapeutics, really, again, underscores the opportunity for us to really help our patient and truly change their lives, which to me is, kind of why we went into this profession. So pretty amazing to get the input from our specialists, and for the restorative dentist that might be seeing this patient, or the periodontist who's seeing this patient, and we all bring our kind of capabilities and, you know, our superpowers to the table to have this type of discussion. Fantastic. I mean, that's all we can say. Something that might look a little simple, now we start opening it up, and like you said, Dr. Robley, peeling back that onion, all of a sudden we start uncovering so much, especially with today's knowledge. Dr. Germ, any closing comments that you'd like to add?
You know, one of the modalities would be for, let's say, a fixed bridge, right? And where I begin to try to learn about the case and educate myself, normally we'll begin with some sort of simulation or some sort of diagnostic setup. And I think that that is a huge tool to help not just, you know, understand the case from the professional level so we can teach the patient, but at the same time for the patient to visually see what may be possible. Because the patient may not be, they may never even think that they've ever needed orthodontics. They're thinking about an implant. And I love the interdisciplinary approach, but I also want to have a solution for the patient that doesn't have the risk of scaring them away. And I'm not saying that our goal is to not provide the ideal, you know, interdisciplinary treatment plan, but always to have a solution for the patient that is, you know, not doing any harm. It might not be ideal, but it is addressing what their chief complaint is at the same time. So I would always begin to educate myself. And when I get a chance to, you know, to see a patient like this and put together that visual simulation, it's the beginning point for that collaboration to begin, possibly with ortho, possibly with perio, possibly with pros, and how we can, you know, achieve what the chief goals of the patient are.
You know, it's such a great point of linking up the visual image to allow us and the patients to see, hey, do we want to go here? And as Dr. Robley pointed out, there's an ideal interdisciplinary approach. But then to your point, Dr. Germ, is really to marry that to where the patient is comfortable, because they might 3 to 5 years down the road say, okay, I'm ready now. But at least we can improve where they are, and they're not sliding backwards from a standpoint of restorative dentistry, and potentially improving some of these other aspects that have all of the medical implications of improvement, like airway, like oxygenating the system, you know, with some of these more definitive changes. So we can offer treatment plans, really 1, 2, 3 treatment plans in phases for our patients to kind of understand their needs. And that only happens through enhanced and effective communication.
Yeah,
And
I mean,
we all know that. We got to take our time.
Definitely. And it's a way to share with the patient, you know, here's a solution that would address, you know, part of your chief complaint, but here's a better solution that's the more interdisciplinary plan that, you know, would really solve the fundamental issues that are leading up, like what Rick was saying, from your entire life to this point. Let's not just try to get a quick solution, but let's try to understand how we got here and solve that issue.
Amen. Yeah.
Amen. Amen. I love it. Great job, team. Again, a case that a patient that looks on one hand, oh, you know, we can do some grafting, we can do some orthodontics, we can make a bridge. And then we start peeling back the onion, and all of a sudden we start to understand all of these structural and biological issues that do need to be addressed, and then communicated to the patient in such a way that we can match the therapy with their mindset so that we can improve where they are today, and then potentially also into the future. Well done, everybody. Thanks so much. Thank you, Dr. Kim, for presenting this case to us. Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.